And I am so glad all of you have joined us, and I'm really excited to introduce our speaker, who has graciously agreed to speak with us about a topic that's really important in our work, multimorbidity. But Dr. Mayuree Rao should be familiar to most of you because she did her internal medicine residency here at UW and then stayed on as a chief resident. But her current role is as an HSR&D fellow over at the Seattle VA. And her work really is very related to what all of us do in practice. She looks at innovative health delivery models and self-management programs and is very interested in the use of community health workers in resource poor settings. So today she's going to talk to us about multimorbidity, and I'm just so glad that you've joined us. So thank you so much.
Good morning, everyone. Thanks so much for having me. I'm really honored to be speaking to you today, and thanks so much, Kate, for that introduction. Just wanted to tell you a little bit more about me. I grew up in North Dakota, which did not have fancy tourist signs like this when I lived there. And as Kate said, trained here. I'm currently at the VA. I have a little bit of clinical time in primary care clinic where I see patients, and otherwise most of my time is spent on research now. And in my off time, I am taking care of this little one. And I have no financial disclosures, but I do want to discuss my intellectual disclosures, the first of which is that, as the painter Ben Nicholson once said, I'm not an expert, but I want to be. Multimorbidity is a topic that I am really passionate about clinically. It's the subject of my research, as Kate mentioned, although I'm not going to talk specifically about my research projects today. But I also know that I am an internist speaking to an audience of geriatricians and palliative care docs who live and breathe multimorbidity every day. So to some extent, I know that I'm going to be preaching to the choir. And my hope is that I can offer at least one new or interesting concept or piece of information for everyone here today. And I really do welcome all of your reflections on this subject. So to frame my discussion of multimorbidity, I wanted to start with an analogy. So the late writer, David Foster Wallace, one of my favorite writers who's pictured here, gave a commencement address at Kenyon College in 2005. And some of you may have read his speech. It was critically acclaimed at the time. It was subsequently published in book form. And in the speech, he relates this parable. So there are two young fish swimming along, and they happen to meet an older fish swimming the other way who nods at them and says, "Morning, how's the water?" And the two young fish, they swim on for a little bit, and then eventually one of them looks over at the other and says, "What the heck is water?" And the point of the parable in the speech is to point out that the most obvious realities are often the hardest to see. And he talks about the importance of cultivating awareness and empathy in this life. But for me, this parable often comes to mind when I think about multimorbidity, because it is so pervasive in medicine, so pervasive among the patients we take care of, really in every specialty. It's truly, I believe, the water that we swim in. And so my version of asking the question, what the heck is water, is what is multimorbidity? I think, other than, present company excluded, I have noticed that it is an entity that we rarely talk about in a really substantive way in clinical training and in practice. And when I first became interested in this topic, I asked myself these additional questions, which were, am I caring for patients with multimorbidity in an evidence-based way? And then this deeper nagging question, is that even possible? So my objectives for this talk are to define multimorbidity, describe its challenges for patients and clinicians, review the evidence on managing multimorbidity, or really the lack of evidence, propose some system-level solutions for improving care of patients with multimorbidity, and describe some tools, at least, for point-of-care best practices for caring for patients with multimorbidity. So let's start with definition and prevalence. I wanted to start with just one conceptual note, which is that there are a lot of terms out there that I think overlap but are distinct from multimorbidity, including high-risk patients, high-needs patients. You know, high-risk patients is usually used to refer to patients who have a high future risk of hospitalizations or emergency department visits. High-needs patients, that's sort of a similar concept. I've noticed that when this term is used, it's usually incorporating social risk factors as well. And multimorbidity, I think, overlaps with those concepts, but is distinct. Patients with multimorbidity may or may not be also high risk and high needs. And then I also, want to say that, I don't have to convince you that this topic is important, certainly, but, just it's worth saying out loud that multimorbidity, of course, is not just a problem in the elderly, and really, really can affect young people too, especially at the VA and the patients that I see. Even my youngest patients are often dealing with multiple chronic conditions, largely because of mental illness and chronic pain. So there are a lot of definitions of multimorbidity that are out there. And this is really just the most basic one, just the presence of multiple chronic conditions. Many organizations really don't get more specific than this when they talk about multimorbidity. But there are a lot of other definitions that are more specific, and I would categorize them into 3 buckets. So there are the definitions that are just based on a count. So counting up the number of conditions. And 2 or more conditions, I would say, is the bare minimum and probably the most common definition used out there. But 3 is a threshold that you'll see a lot. Another category of definitions is what I'm calling count plus, which is not only counting the number of chronic conditions, but also incorporating some other features in the definition to capture some additional complexity. So this idea of body systems, crossing 2 or more body systems, is sort of getting at the point that, someone with hypertension and coronary artery disease doesn't have multimorbidity in the same way as someone with, for example, coronary artery disease and depression. Some of these count plus definitions incorporate severity, symptom burden, function, and many of them count the number of conditions, but only among a specific list of conditions that they've generated that really meet some threshold of requiring ongoing daily care. And finally, there are the indices, the multimorbidity indices, and there are a lot of those out there, 35 according to one recent systematic review. They all incorporate some kind of weighting in which different chronic conditions are weighted based on their risk of the associated risk of some long-term outcome of interest, like hospitalizations or mortality, for example. So how do people choose in clinical guidelines or in research? How do people choose among definitions? It's really based on the question, based on the clinical question, based on the research question. And I think the reason this is hard is because when we say multimorbidity, that really means something to a patient and to a clinician. And it is a challenge to sort of capture the difficulties of being and caring for someone with multimorbidity in a definition. So just one slide on prevalence. This is all older data that I collated, but I think qualitatively this still feels right. These are just 3 studies looking at prevalence of multimorbidity in different populations. So you can see among Medicare beneficiaries in 2010, 2/3 had 2 or more chronic conditions, about 1/3 had 4 or more. veterans over the age of 65. In 2007 and 2008, almost 90% had 3 or more chronic conditions. And then even in a large study, a large national study of primary care patients just over the age of 18 in 2011, a little less than half had 2 or more chronic conditions, and a little less than a third had 3 or more. So I think this is just data to support, I think, what we all experience every day, which is that multimorbidity is really common. So what are some of the challenges of multimorbidity? From a patient perspective, and this is certainly not an exhaustive list, care fragmentation, having to see multiple different specialists, treatment burden, including healthcare visits, self-management tasks, medications, the burden on caregivers, functional impairment associated with, the cumulative effect of having multiple chronic conditions. There is a mental health impact, certainly, of having multimorbidity, and then just overall reduced quality of life. Rather than show you data, I wanted to just show you some quotations that I pulled from multiple different qualitative studies that have been done among patients with multimorbidity. It's really difficult because all of the things that are going on around me, I can't really control, and I can't plan anymore. Everything is a jumble, and I lose track of where I am up to. There is stuff that I am supposed to do and stuff that I actually do. If I did everything I am supposed to do, my life would revolve around doctors and tests and such, and there wouldn't be very much left for living my life. So I've made a bunch of choices. It's not the disease that I'm fighting, it's the healthcare system. I did want to share some additional information about this idea of treatment burden and patient workload associated with having multiple chronic conditions. So this was a study that took 6 chronic conditions that are listed at the top there. They looked at the most recent clinical guideline for each of those conditions. And based on the guideline, they counted up the number of medications per day and the number of clinician visits per month that would be recommended if you were following everything in that clinical guideline. And they did that for each of these conditions and then reported those numbers for kind of every combination of conditions. So that's what's on the left here, where it says 1, 2, 3, 4, 5, 6. So just looking at 3 conditions, there were 20 combinations of 3 conditions from this pool of 6. And median number of medications, if you were following the guidelines, would be 10. And number of visits per month would be 5.1. I think seeing those numbers is even though that certainly feels right based on patients I take care of with 3 chronic conditions, I think it's rare that I stop and reflect on how much my patients are really doing. And it's even more for 4, 5, 6 conditions. Same study, just a different way of looking at things. So they also looked at each of the recommendations in all of those clinical guidelines, and they did literature reviews to try to identify how much time enacting each of those recommendations would take for a patient, from self-management tasks to taking medications to the clinician visits. And so on the x-axis here is hours per month. And on the y-axis is just every combination and number of conditions from, again, those pool of 6 conditions that they were looking at. So if you look at this 3 diseases category, you can see that if you were following all of the recommendations in the clinical guidelines, you would be spending 70 to 80 hours a month just taking care of your medical conditions. And if it's 6 or more, or sorry, if it's 6 conditions, it's over 80 hours a month. So what are the challenges from the clinician's perspective? Again, not an exhaustive list, but care coordination, that's sort of the corollary of the care fragmentation that patients experience. The difficulty of applying clinical guidelines to patients with multimorbidity. I'm going to talk more about that in a few slides. Short appointment times and clinical prioritization is very challenging. Again, some quotations from qualitative studies of physicians on their experiences managing multimorbidity. We never get criticized for doing too much, but you can be sure you'll get in trouble if you haven't done enough. We're much more vulnerable to the entire healthcare system's expectation that things must be done. There's an intense action imperative to do more. This is just referring to the poor applicability of clinical guidelines to patients with multimorbidity. So the insecurity that a guideline hell brings. And this is not from a qualitative study. It's a line that I really like from a perspective piece on multimorbidity by a British geriatrician, referring to short appointment times. So in life, as in the film, little happens in brief encounters. And that's a 1940s film that I haven't seen, but maybe some of you have. So, these challenges, if it feels like these are just the challenges of practicing medicine, period, not just related to multimorbidity, I would certainly agree with you. And so would the authors of this piece on multimorbidity, in which they stated, multimorbidity serves as an avatar for the fundamental recurrent problems of modern medicine and the organization of care. So given those challenges, what do we have in terms of evidence for managing multimorbidity? And I wanted to start with a line from the same perspective piece from that British geriatrician I mentioned earlier, in which he says, evidence-based medicine is perversely a monument to bias. What this means is that, evidence-based medicine has excluded many patient populations, not the least of which is multimorbidity. So in this study published a couple of years ago, what they did is they did a systematic review of clinical trials. And for each clinical trial, they looked at the clinical population that trial was drawing from, the clinical population that trial was studying. And they calculated what percentage of patients in that clinical population would have been excluded by applying the exclusion criteria specified by the trial. So you can see that a quarter of trials excluded 89% of patients or more from the clinical population that they were studying, and 3/4 of the trials excluded 56% of patients or more from the relevant clinical population. Age, gender, representation of race and ethnic groups, those are all huge problems in clinical trials. And so is multimorbidity. That study found that comorbidity was an exclusion criterion in 67.2% of trials. There's an older JAMA study that with slightly different methods that found that 81% of clinical trials excluded patients on the basis of medical comorbidities. And I think there's a lot of nuance there. Some of that might have been appropriate. A lot of it probably is not and has downstream impact that affects us all. So looking at disease-specific guidelines, this is just a reproduction of a table from a study that looked at a bunch of chronic diseases and looked at whether and how multimorbidity was mentioned in the clinical guideline. And this is an old study by this point, but I did put asterisks next to hypertension and COPD because I think those guidelines have improved in their handling of multimorbidity since this study was published. But still, I would say the overall picture is pretty poor. It's very rare for guidelines to even discuss the quality of their evidence for patients with multimorbidity, let alone provide specific recommendations and information about time to benefit to help clinicians taking care of patients with the condition in the guideline, but also with other conditions. There are guidelines on multimorbidity, of course, specifically, which I'm going to get to in the next section. I think the fundamental problem is that it's impossible to be exhaustive. COPD, for example, if you look at the most recent GOLD guideline, They have now, a paragraph each on 5 or 6 different chronic conditions that are often comorbid with COPD. And it's sort of a little snippet on each condition saying these are some things you might think about if you're taking care of someone with COPD plus X or COPD plus Y. But it's still a little bit unwieldy, and you're not necessarily going to find your patient in that list. So I'm going to pivot away from guidelines and now talk about multimorbidity interventions. So what interventions at a clinic level, practice, healthcare system level have been studied to improve the care of patients with multimorbidity. And there was a systematic review published just last year that looked at all of the trials of multimorbidity interventions. There were 16 of them, 8 of them just randomized control trials, I should say. 8 of them tackled care coordination, 4 of them self-management support, and 4 of them medication management. And a lot of different outcomes were looked at across these trials. One of the more common outcomes was health-related quality of life. So the study authors just pulled the trials that looked at quality of life and did a meta-analysis. And you can see here in this forest plot, if you look at the big black diamond below, that is just showing you that it crosses 0. So there was no difference really in health-related quality of life as a result of all of these interventions when you pool the data together. But even if you look at kind of the individual interventions and the subgroups of interventions, there was no real effect. And I will say all of the other outcomes that were looked at across the trials, things like treatment burden or healthcare utilization, really minimal, if any, effects from these interventions. I think there are a lot of challenges. This is a really clinically heterogeneous population to design an intervention for. It's hard to come up with outcomes that are relevant to this whole population with very different mixes of diseases. And you have to think about the follow-up time. A lot of those challenges for both patients and clinicians that I addressed earlier are really entrenched and really fundamental. Some of these interventions were 6 months long. I think it's important to think about how long it might take to make a dent in some of these outcomes. I wanted to pull out one of the trials covered in that review, just to give you a sense of some of the kinds of interventions that people do. This is the largest trial that has been done to date, largest randomized controlled trial of an intervention on multimorbidity called the 3D approach. It was conducted in general practices in England and Scotland in patients over the age of 18 years and with 3 or more types of chronic conditions. So practices were randomly assigned to provide usual care or a comprehensive 3D review every 6 months. I'm going to talk about what that was in a second. The primary outcome was quality of life, assessed after 15 months. So what was this 3D review? So the intervention was to complete a comprehensive multidisciplinary review once every 6 months. The review included a nurse appointment, a physician appointment, and a records-based review by a pharmacist. The nurse review included identifying the health problems that the patient considers most important and how those problems affect their lives, doing some screening for depression and dementia, discussing social resources, doing some disease-specific stuff regarding health parameters, health promotion advice, and then at the end, printing an agenda document for the patient to summarize everything. Added to that agenda document was a pharmacist review of recommendations to optimize and reduce medication burden. And then finally, in the physician consultation, all of those recommendations are reviewed, and there's a discussion of how to align care to those priorities. And the end product is kind of a health plan moving forward. So what were the outcomes here? This first line at the top is the effect size for the primary outcome, which again was quality of life. And as you can see, the difference in means is 0. So essentially, there was no difference between the usual care group and the intervention group at the end of the trial in quality of life. But if you look at some of the measures they did of patient-centered care, there were positive effects in the intervention group compared to the usual care group. So some reflections, only about half of the patients in the intervention group had 2 of these multidisciplinary reviews in 15 months as intended. So it wasn't a great fidelity to the treatment. 75% had at least 1. You could argue, and the authors propose that perhaps this intervention was not intensive enough to really make a dent on quality of life, especially when you think about some of the components of that quality of life measure, which include things like functional status. Maybe doing a multidisciplinary review every 6 months is not really going to help functional status. And then I think it's important to point out that, even though it's disappointing that quality of life did not improve, patient-centered care did improve, and that is certainly a worthy goal in and of itself. My conclusion from that systematic review, from all of the interventions on multimorbidity, is just that there's still a lot we don't know, and that we're figuring out about how to really enact some of the recommendations for caring for patients with multimorbidity that have come out over the past 2 decades. How to really enact those in an effective way at a system level in terms of kind of practice reorganization, I think is still unknown. So next, I want to just discuss some system level solutions that experts have come up with. These are really high level, even philosophical solutions to this challenge of taking care of patients with multimorbidity. And so the first item is just recommendations for developing evidence that better applies to patients with multimorbidity. These recommendations come from a summary of a conference on improving guidelines for multimorbid patients. It was published a few years ago. And I'm just pulling out a few of their recommendations. So identifying, defining, measuring, and routinely reporting important and common comorbid conditions in clinical trials. Do not explicitly or implicitly exclude people with multimorbidity from trials. And then analyze the heterogeneity of treatment effect across multimorbid subgroups. And the authors recognize that for a new treatment and initial efficacy trials, it's probably unrealistic to expect trialists to measure treatment effects across all patients and settings. But really, once efficacy is established in a certain population and setting, we really need additional studies to generate evidence of the effect in subgroups of patients with multimorbidity. There are a lot of barriers to that. Enacting these recommendations requires some things, including reliance on multiple study designs beyond RCTs. Doing this will require more numerous and larger clinical trials, and that probably requires a reimagining of how clinical research is integrated with healthcare delivery. And then I think this is a really interesting point, which is that regulatory agencies, journal editors, and professional societies need to demand this evidence. I think we as a professional community need to demand that that evidence is generated not just for very narrow populations, but for the populations that we take care of every day. There are also multiple groups that have come up with recommendations for clinical guideline development. This is one of them from the Improving Guidelines for Multimorbid Patients Study Group that published their recommendations in 2014. I'm not going to go through all of these, but just pulling out a couple of them. So in the step of commissioning a work group, the authors point out that generalists should be included, even in specialty society guidelines. It increases the likelihood of a guideline that will be relevant to a general population. All of these clinical guidelines include a systematic review of the evidence, and this study group encourages people to think about the trade-offs inherent in the criteria for eligible study designs included in these reviews. If you're only going to include RCTs in your evidence review when you're developing a guideline, you're going to miss evidence that is more relevant to patients with multimorbidity. Guidelines should always assess how benefits and harms of treatment change in people with coexisting conditions. They should specify the time horizon for the net effect. And their recommendations should account for subgroups with coexisting conditions. And the strength of their recommendations should also account for subgroups. So that's all very well and good. I think it is helpful to just take a big step back and remember that the whole point of multimorbidity is that there is no index condition. And one can think about how we might reimagine guideline presentation entirely. Instead of reading a separate guideline for every condition, what if we were presented different recommendations depending on demographic and clinical information of the patient? There have been a couple of prior papers that have thought about this. I'm not going to go through these tables in detail. I just wanted to give you kind of a visual of what that might look like. You can imagine entering into some website, your patient's age and all of their chronic conditions, and getting some kind of output that extracts the relevant recommendations across all of the clinical guidelines, summarizes them for you, identifies where there's interactions, and identifies where there's synergies. And this would be, a completely different way of thinking about guidelines. This last slide in this section is a little ambitious, but I just wanted to point out a few themes about that I think are related to the culture of medicine and how we practice medicine. And these are things that I think need to change long-term if we are to better take care of patients with multimorbidity. And the first is that practicing evidence-based medicine means starting with patient goals. That I know that's not a controversial statement in this audience, but there is often presented this false tension, I've noticed, between evidence-based medicine and providing care that is aligned with patient goals. And even among those who live and breathe patient-centered care, sometimes the language used still implies that the starting point is whatever the guideline recommends, and then we modify and we make trade-offs to align with patient preferences. But the reference point is the guideline and the trial. And the treatment plan always has to justify any deviations from the guideline. And I think when it comes to better taking care of patients with multimorbidity, it can be helpful to just reframe that discussion entirely. Starting with a patient's goals is, in my view, is not a compromise on evidence-based medicine. It is evidence-based because it recognizes that the guidelines don't perfectly apply to the person sitting in front of you, just based on the merits of the existing evidence without even invoking the patient's goals and priorities. And so I just think we need to talk about patient-centered care as evidence-based. I also think we need to take responsibility for the fact that some non-adherence is structurally induced by the healthcare system, which is a line from a piece on minimally disruptive medicine published several years ago. And what do I mean by that? So we need to change the way we think about behavior change, self-management of chronic disease, and adherence to treatment plans. In studies upon studies examining non-adherence, the focus is primarily on individual level factors. So, how do we provide the motivation, the skills, the knowledge, support to enable someone to change their diet, for example? And that kind of work is certainly worthy, and I'm doing research in that area as well, but it doesn't account for the fact that our fragmented healthcare system and our poorly fit clinical recommendations are responsible also for generating an enormous, extraordinary burden of time, money, personal resources required for a patient with multiple chronic conditions to actually follow a treatment plan. And then the final theme is just that we need to reorient quality measurement towards multimorbidity and patient-centered outcomes and away from single diseases. And the issue of quality metrics, and especially quality metrics and multimorbidity, is a completely different can of worms and could be a talk in and of itself. But I just wanted to introduce that theme because I think it's important. Okay, my final section is on is trying to get a little bit more practical. You know, what can individual clinicians do to better take care of multimorbid patients in their own practices. My goal with this section is really to just, and especially if there are trainees in the audience, just to point out resources without going into each of them in great depth, just to point out resources to get to know to help better take care of patients with multimorbidity. And the first, of course, is the clinical guidelines that exist on multimorbidity. So, you know, the American Geriatric Society, of course, has a great multimorbidity guideline. They also have a really great framework for decision-making based on their guideline, which is at the top left. And their kind of three-step loop is identifying and communicating a patient's health priorities and health trajectory, deciding on stopping, starting, or continuing care based on those priorities and the health trajectory, and then aligning all of those decisions across patients and caregivers and other clinicians. The bottom figure here is a graphic of the Ariadne principles, which are recommendations for handling multimorbidity in primary care that were developed by a group of experts from North America, Europe, and Australia in 2012. They were named for a Greek mythological figure who helped Theseus escape the Minotaur's labyrinth by handing him a ball of thread, with the idea that having multimorbidity can feel like being in a labyrinth. And I think their recommendations are very similar. And on the right is a graphic from the guideline from NICE, the National Institute for Health and Care Excellence, which is the body that develops guidelines and makes decisions on which treatments will be offered by the National Health Service in the UK. Also has a really nice multimorbidity guideline, which again is pretty similar in content. So I think getting to know one guideline, some guideline is a really important step. And I wanted to just, so there are a lot of steps in these guidelines, a lot of recommendations. I wanted to pull out just 2 recommendations that are common to all of these guidelines, with the purpose of showing a resource, a helpful resource where you can learn more about how to kind of enact that recommendation in practice. One of them is, so starting with a goal. So all of those guidelines, any guideline on multimorbidity usually says that, really clinical care should be oriented around patient goals. And so one way of doing this is using the system called Patient Priorities Care, which is a system of care developed by a team led by Mary Tinetti, a geriatrician at Yale, that's seeking to better align care with patients' values and goals. It's referenced in the AGS guideline as a validated resource for thinking about how to elicit and then align care with patients' priorities. So on the bottom left here, this system recommends eliciting values, discussing actionable goals, healthcare preferences, specifically what care do you find burdensome, what care do you find helpful, and then identifying the one thing that a patient most wants to address. In this system, this process is supposed to be completed by a trained facilitator, not necessarily a physician, not necessarily a physician or an APP, but some kind of trained facilitator in a separate appointment, and then documented in a note. And then every clinician visit starts with priorities. I think it's interesting to reflect on one's own practice. I mean, I think about, still when I pre-chart before clinic, do I write down the list of conditions that I want to cover, or do I write down patient goals? In a visit with a patient, are we ticking off conditions, or are we framing things in terms of goals? And I think, especially in training, we should be teaching trainees to do this and to orient a little bit more towards this system and away from disease-specific orientation. So anyway, there's a website, patientprioritiescare.org. The landing page is what I've kind of pasted at the top there, and has a ton of resources and tools and a lot more detailed information about how to do this. The second recommendation that I wanted to pull out is this idea of incorporating time to benefit in clinical decisions. And this is the idea, for those who don't know, that for every treatment, there is a time that you have to be on that treatment before you would be expected to achieve a benefit. But that time to benefit is very, very sparsely reported in clinical trials or in clinical guidelines. Often the raw data is there if you look back at the evidence, but it's not really reported to you. And it's so important. It's important for everyone, but particularly important in patients with multimorbidity, where trade-offs have to be made. I just wanted to point out this tool, if anyone is not aware, or again, if there are trainees in the audience. So NICE, the British organization, or the UK organization, has a database of treatment effects associated with their multimorbidity guideline, in which you can select a chronic condition, you can select an outcome, and what they have done is they have gone back to the original data and kind of calculated time to benefit statistics for a number of kind of chronic condition treatment outcome triplets. So this is just an example that I've pasted here for hypertension and for the treatment antihypertensive drug therapy, looking at all-cause mortality. So the number needed to treat per year, again, that per year part is really critical, is 1,050 to prevent one death. And there's a confidence interval associated with that, which they also report. So this is a really nice resource too. There are a lot more recommendations and tools out there. Prognosis is really important. There are a ton of prognosis tools out there. I just wanted to pull out two that I think are talked about a little bit less than prognosis. Okay, summary slide. So just want to cover what I covered, which was multiple definitions of multimorbidity, the numerous challenges for clinicians and patients, the fact that applicability of guidelines to patients with multimorbidity is really problematic. There is weak evidence for interventions to manage multimorbidity. I talked about some system level solutions, including generating evidence, guideline reform, and about the culture of medicine, and just briefly introduced some tools for point of care practices, including getting to know a multimorbidity guideline, starting with the goal and incorporating time to benefit in clinical decisions. So thank you so much, everyone, for your attention. I want to end by again saying that I know I'm speaking to an audience of experts. I really welcome your questions and your reflections. Thanks again. And this is a QR code for evaluations.
If anyone has questions, you can feel free to unmute, or if you type them in the chat, we can read them if you're not able to unmute.
I see a question in the chat. Thanks so much for that. So could you please describe what studies are being done to assess application of PPC approach for efficacy? So I'm happy to talk about a little bit about what's been published. And Kay, it sounds like you work on this. So if you would like to talk about it, that would be great. You're raising your hand. So Kay, please go ahead.
Yeah, no problem. Thanks, Elizabeth, for that information. There's a couple of randomized trials that are currently looking at this in a variety of populations. So far, patient priorities care has been mostly studied in a few kind of discrete clinical settings. One is which, like I'm sure that she's familiar with, which is in a outpatient clinical setting in a cardiology clinic. And that like they looked at a variety of factors. So they looked at medication reductions, they looked at some levels of patient efficacy, they looked at provider and family / caregiver like efficacy or more or less like kind of satisfaction. I forget exactly what their measures were, but that's where the majority of the evidence base has come for patient priorities care. They've also looked now in a variety of other clinical settings, both outpatient geriatric settings. Some of them have been in the VA. And now there's a new randomized control trial that's looking at basically integration into a hepatology clinic down at the Houston VA. So that trial's getting up and running like as we speak. But there's interest and like wider dissemination in a variety of clinical settings, and really trying to focus on not just necessarily long-term kind of outcomes, but really more the person patient-centered outcomes and satisfaction, and then looking at some chart reviews to try to better elicit kind of this alignment of care, which is very elusive and difficult to kind of do. But that's kind of where the efficacy comes from.
Thanks so much for that. Dr. Wang is asking, do you have any more information on the indices used for multimorbidity and what particular conditions were weighted more highly? Yeah, so the indices used for multimorbidity are, just to give you some names, it's an interesting group of indices because I think they're variably used they're used a lot in research. I don't know that they're used in kind of clinical practice as much, but the Charlson, the Elixhauser, the Gagne index, these might sound familiar. Some of them, like the Gagne index, are used for prognosis too, kind of can't be used clinically, are included in the UCSF ePrognosis website. The weighting of the conditions, I wouldn't be able to tell you off the top of my head. I can tell you that they vary among the different indices, and the weights are based on kind of large population studies looking at which ones predict mortality the most. And I think because the indices, the purpose of the indices was really about prediction, rather than as kind of a clinical tool, sometimes the weighting can feel sort of opaque and not very relevant to clinical practice. It's sort of whatever the statistical model spit out, and it may not kind of feel like it resonates with patient care.
It looks like Mary has a comment about the impact this has on the caregiver or spouse, all of the time spent in care. So. Yeah,
I think that's a great point, and really important. And I think, yeah, part of the strategy of better taking care of patients with multimorbidity is definitely considering the whole family, and including caregivers in that conversation.
I wanted to just point out we have, I hope she doesn't mind, Mary Pat O'Leary from King County Aging and Disability Services. She's a nurse planner with them. I don't know if you've met, but you should. She's done a lot of work with the chronic disease self-management program that they offer through the Area Agency on Aging. And I don't know, Mary Pat, if you'd be able to unmute and just comment on that and how it relates to this talk, because I know this is a passion of yours.
Thank you, Dr. Bennett. Yes, this is, it's so important, I think, involving the patient and the family caregiver into this conversation. I'm actually providing care to two people, a former spouse who's a veteran and another older adult. And what I'm finding is that they really feel like they don't have any control or any say in their life. And by introducing something like chronic pain self-management or chronic disease self-management, or even as building better caregivers through the VA, it is so impactful. It's so powerful to see folks saying, you know, I actually took an hour for myself today, and how much that meant to them. And also as they're learning as caregivers how to really have that upfront conversation with the healthcare provider, there's less stress, there's less anxiety. You can actually see in the documentation this decompression of the caregiver and how their relationship with their loved one has changed. So in the chronic pain self-management, people who have had catastrophic head injuries have said, I didn't think I could exercise or move my joints. I felt like it wouldn't do any good, but they have had, you know, substantial improvement. So I think it's just those little kernels of what is possible, and then it builds on that. So yes, thank you.
Mary Pat.
Thank you for those reflections. That's really inspiring.
Oh, I think just to piggyback on Mary's personal experience, I think that there's a lot of these interventions that you described that are really powerful, and they're powerful at these micro levels. And I guess I wonder whether a lot of the primary outcomes that they're using, like these quality of life studies that incorporate all these different components, don't adequately actually capture that. And so yeah, I just wonder whether they're actually just looking at the wrong primary outcome and thinking more about, you know, preventing ED visits, for example, or maybe looking at the spouse's quality of life. Because in dementia, a lot of the outcomes that we look at is actually the caregiver's perception and not the actual patient's experience.
Yeah, thanks for that comment. I think that's a great comment, and echoing that, Dr. Phelan's in the chat about considering relevant outcomes. Yeah, and I think that is an issue that has plagued some of the research on multimorbidity interventions, for sure. There's still sort of a disease-specific orientation to research in this field, and we definitely have to move away from that if we really want to capture the benefit and understand the potential benefit. There's a great paper, I'm forgetting who the authors were, where they kind of came up with sort of a minimum set of relevant outcomes for research on multimorbidity, which some of the newer trials are now referencing when they select their outcomes. But I think, as you're implying, it's also just a philosophical question. Like, what is really our goal here? You know, when you're designing an intervention to better care for multimorbid patients, what are you really trying to change? What is important to the patients to change? Dr. Carpenter, I wonder if you want to say more. Yes. Yeah, first visit to cardiology, and the goal is to cut down on medications. I think.
Yeah, right. And just to the point that you know, if only we could get everyone to think about what the patient's goals are. He came in wanting to cut down his meds. He's on 2.5 of lisinopril twice a day, you know, all the heart failure with reduced ejection fraction meds, already on a Torva 80. He's 88. We did a pulse. He was DNR, kind of leaning toward comfort measures only, but eventually decided selective. And then I come in this morning and there's a message from the cards NP like, oh no, look at his LDL. And I'm like, well, but if we think about this guy that I just met yesterday, you know, I only met him for the first time and she's been following him for a while, but obviously his LDL is not his priority when thinking about his healthcare and how it fits into his life.
Yeah, thank you. That's such a great example. And you know, I didn't talk about this much, but I probably another theme that I would add to the culture of medicine is just that I think a lot of times we are talking a lot about these issues in internal medicine and in geriatrics and palliative care, but this is an important issue across specialties, and I actually love that patient priorities care has been studied with cardiology clinicians. I think that's great, and I think there needs to be more kind of cross pollination. I'm not implying that, you know, no one in subspecialties is thinking about this. I know they are, but I think there can be a little bit of a disconnect. And there are lots of patients with multimorbidity out there whose really de facto primary care provider is a cardiologist, you know, or is a specialist of some kind. And yeah, which is why I think these issues are really relevant across medicine.
Great. Well, we're getting close to 9 o'clock here. Thank you so much for this fantastic talk. You covered quite a bit, and I learned some new ideas and resources today. So thank you so much, and I appreciate you taking the time to answer all of our questions. And we're excited to see where your work heads, because you're doing important work and you're clearly passionate about it. And we're excited. We hope you come back and tell us what you did. And what fantastic things we can learn from you, from your research.
Thanks so much. Thanks, everyone. Again, really, really honored to talk to you, and thanks for the discussion. Hope you all have a nice long weekend.
I'll take care, everyone.
Bye.